Hello and good afternoon, Mamlaka. This is our midweek program, Midweek Vibes, and we are so glad to welcome you to the program today. I'm joined by two professionals, and I'll ask them to introduce themselves. On my right, please introduce yourself, Margaret.
Thank you very much, Reverend Maggie, and good afternoon to Mamlaka. It's a pleasure to be here with you again. My name is Margaret Njehia. I am a clinical psychologist, and I also work at the Technical University, and I'm humbled to share the plenary today with my lecturer.
Thank you so much, and welcome once again.
Thank you.
One more time, actually.
Yes.
And on my left is our guest. Please introduce yourself.
Thank you very much, and good afternoon, Reverend Maggie, and good afternoon, Mamlaka Hill Chapel, and our viewers. I'm Dr. Francisca Ongecha. I am a psychiatrist, and I'm also a lecturer at Kenyatta University. I'm happy to be here. You've just heard, my student is here. So that confirms to you that I'm actually I'm a lecturer. And thank you very much, Margaret, for sharing a platform with you. You can imagine, it's going to be an interesting one as well. Yeah. So thank you.
Thank you so much, and welcome both of you. We are so delighted that you can share this platform with us. And last week, if you all remember, we looked at depression among the emerging adults. And we wanted to have a part 2 because last time we covered the way to identify them. Who are they and how do we identify them? That was covered very well. And we also looked at some of the issues that afflict our young or emerging adults. And I'm going to ask our Daktari here, Dr. Ngecha, to let us know what are the issues here? Is depression prevalent among them? And how is that related among the diseases that afflict them? Daktari.
Thank you very much, Reverend Maggie. I think you remember when we were talking here last week, we did mention a few figures. You know, when you talk about what makes sense is figures. And I think today people are quite aware that they just want to hear what were the figures today, even when it comes to COVID-19. So that tells you that actually people listen to figures.
Yes.
And for the emerging adults and the depression that we are talking about today, one of the major issues is that depression is very frequent. And I want to go broad. Yeah, globally, we have about, we're talking about the global burden of disease, we have about 264 million people in the world who are affected with depression or suffer from depression. Not affected, suffer from depression. Affected is basically a bigger number because you can imagine the whole family.
Did you see 264?
264 million.
Million people?
Yes. Then,
that's a large number.
That's a big number. Now, what is it about the emerging adults? Yeah, the thing is that 50% of those who have depression have the onset before and around this age. So that is the other challenge that, yeah, the people, of all those people who suffer from depression, a lot of them would have the onset in this period. Yeah, so that's another issue. Then the more reason why we really need to talk about depression among this population. Then the third one is that, you know, there are common diseases that would be affecting different groups of people. Yeah, you know, like we talk about children, what are the top 5 diseases, top 10 diseases? Yeah. For this group, the top 4 diseases, I mean, the number 4 of the top diseases that they have is depression. So you'll have number 1, 2, 3.
Number 4.
Then number 4
is depression.
Depression.
Wow.
So it's not something that you can push to the back and say, yeah, okay, it's 50%, but maybe not a big deal. But when you look at that, then you really say that there's something we must do. And as we talk about depression again, we'll also be able to realize why it's important because it does affect different aspects of anybody's life and functioning.
Wow.
Yeah, and I think this is a very good forum, at least for us to be able to highlight these issues about depression that we didn't talk about last week.
Wow, yeah. I appreciate that very much, especially figures are important. I had looked at figures the other time, and I found that 75% of the entire African population, 75% is young people. And I think that percentage of young people, 75 being young, the emerging adults are among them.
Yes.
And I think we shall challenge universities especially to keep giving us the updated figures, because they're the ones who are doing research. They are the ones continuously educating us on the facts on the ground. And that's a very good thing. Now,
Maggie, let me just bring this thing much more near home. Yeah. Sometimes also, sometimes people will be asking, who are those who are depressed? We have these issues that sometimes people like asking. Who are those who are depressed? Maybe they've not seen the depressed person. But then again, we have data, local data for this country. In 2017, actually, we were registered as the 6th country in the world recording high depression. Number 6.
wow.
Yeah, and by WHO, the statistics that WHO picks, it picks figures from different aspects of our data in terms of even the health, the people who are seen and that. And about 1.9 million Kenyans were actually at that time documented to be suffering from depression. These are diagnoses made, not imagined. Yeah.
Yes,
Yeah.
these
So
are actual
the
diagnoses.
different aspects of different areas of data collection. Yeah. So it's something that is with us that I think we want to really look at it as it is here. Yeah.
I think what you just said is so important to know that it's with us.
Yes.
It's our children. It's our students at the university. It's our young employees. It's the young people in our community. So I think that's an important, it's an important area of focus for us as a church as well, because we do not want to be ignorant on the facts on the ground about the populations that we minister to. So I think I want to appreciate that very much. And those figures help us realize that we need to pay attention. We can't ignore. Now, our diagnosis is done by our doctors, our medical doctors, our psychiatrists who do the diagnosis, and also our clinical psychologists will do the diagnosis. Why? Why are the two professions very important in helping us in this area?
Thank you, Reverend Maggie. And just allow me to add something to what Daktari has said that also helps us understand the numbers and the statistics. From the same study of 2017 by WHO, Kenya, I think, was ranked, either number 13, Daktari, in suicide.
Wow.
Yes, I think it was number 13. And we are talking about a very high relationship between depression and suicide.
Yes.
Like really high. So when we score high on suicide, it also goes to tell us about two things, depression and also about substance use. Those two go together. So just to also let people know that when someone is suicidal, there's a very high likelihood that they're
There's
depressed.
substance abuse.
Yes,
And they're likely to be
that
depressed.
they are depressed. So
Yeah.
those are not numbers to be proud about. They are actually very worrying. And especially also because the ones, like Daktari has said, those are the ones who are diagnosed. Because maybe they went to see a psychiatrist, a psychologist, or they went to a hospital. Then there are so many others who are undocumented out here. So we should, the number, if everyone was documented, then the numbers would be
Most
more
likely
worrying,
be
yes,
higher.
than even that. To come back to your question of diagnosis, and let me also put this disclaimer, even when we talk about the symptoms, we are not saying because you have met the minimum threshold of the symptoms that you give yourself a diagnosis. Because to give a diagnosis, there are so many other things that we look at. It's not just because you have a low mood or you've lost interest or you're suicidal, you have impairment in thinking, change in eating and sleeping patterns. That's not just it. That's just one bit
Right.
of making the diagnosis, because there are so many other factors that we look at. And The psychiatrist and the psychologist, either of them can make a diagnosis. And for you to make a diagnosis, even though you have the symptoms that are meeting the criteria, we still go a step further and we administer a screening tool or an assessment just to also, it's going to be different, a bit different from someone who has mild level of depression. So it's not what you read and Google to the
Dr. Google
person
is,
to the person
on focus
watching.
here.
Don't just go to Dr. Google or Professor Google. There's a lot more that we take into consideration before I, as a clinical psychologist, can refer that patient to Daktari and say, this is my assessment. I will also let Daktari know this is what I used to screen. I used this tool and they are at this level, and I also assess what are the triggers so that in the event there are two disorders together, then I'll let Daktari also know, and you're dealing with more than one. Yes.
Wow, that's very interesting that the diagnosis will begin with a psychologist. Can it also begin with a psychiatrist?
Yes, it can.
Yes?
Yes.
So, Daktari, when a patient comes to you, what do you look at?
Okay. When a patient comes to me, of course, there is the bit of checking the history. So in that history, we go through where you have come from. In other words, how have you been up to today? Where are you today? And where you are going? Yeah. Yeah. So that would be able to, I would be able to get that because where you are going are like, these are the plans that I have. Yeah, but probably my current situation seems to be doing 1, 2, 3. Then after taking the history, we do an examination. We do a physical examination and a mental examination. And that would be able to bring out what the signs that I can see, the issues. Sometimes people wonder, how do you examine the mind?
Yes, that's a curious thing.
Yeah,
Yes.
how do you examine the mind using words? And sometimes they think that it's very strange. And Reverend Margaret, don't stop talking to me because I'm not examining your mind now since you are not my client. You know, sometimes the moment we say that, people are like, oh, so all this
I'm
while.
gonna be reading my mind.
All this while. So you've just been reading my mind here. No. When it comes to an examination, it's an examination. Yeah, and it's quite specific. Yeah. So in the history, we ask about yourself, what brings you to us that day, how you've been, any other medical or psychiatric issues you've had before, or emotional issues you've had before, your family, because we really want to understand your family.
Yes.
Yeah, because all these are components of your care and also can contribute to your situation. Because remember what we talked about, that there are many things that are happening. So again, we'll also ask about your relationships before. In other words, you as a person, how have you lived your schooling? How do you relate with people? General life, because remember I said the history is who you have been up to where we are. Yeah. Then
And
of
what
course,
brings you here?
Yeah, what brings you here? Then
where
if you
you're
are
going.
using any substances, if you've had any issues with the law, yeah. A lot of things. And basically, what kind of a person have you been in terms of personality? So when we put all that together, then we are able to understand the person in front of us or the person we are communicating with. Then now we do the mental assessments. Yeah.
Wow. Is it different from what a psychologist would do?
When it comes to the assessment, we'll do the same thing. Now, the departing point between what I can do and what Daktari can do, I can do the assessment very well, use the tools, use the mental status, examination very well. The only thing I cannot do is treat from a medical point.
Yes.
Because
I think let me help Margaret. Put it this way: you cannot prescribe. You know, when you
Yes.
say treat, then people will be wondering, how then are you treating me? Yeah. So
Yeah.
the thing is, it's only the prescription.
that I can't
That
write.
paper
Yes.
that you go with to pick the medication is the only difference. Yeah, that
So-
is all that she cannot do.
So
but she can treat.
you give the medication?
Yes.
You prescribe the medication?
Yeah, it's only the prescription
Uh-huh.
that is the difference between me and her.
Yeah.
Yes, and the psychologist. Then the psychologist has many more other techniques of treating, which we call when people talk about therapy, the psychotherapy. So that is where we
You part ways.
Part.
Uh-huh.
Yeah. That
So-
is where we part.
But do you ever combine? For example, will you give prescription medicine, and then the psychologist will take over from there and also do some therapy?
We actually complement each other. So, like Daktari says, I'll do that assessment and I'll arrive at the diagnosis. And I can justify and qualify my diagnosis and differentiate my diagnosis from the other mental disorders. And I'll do that report. And I will send that report of the assessment to
Right.
Daktari, and she can confirm that. Then Daktari will prescribe the medication and send the client back to me for continued management. Now, interesting, I understand all the medication she has given, and I understand what each of the different medicines she has given and what it does and what it's supposed to do, including the side effects and everything else. And now I will pick it up from there because depression doesn't have a cause, but it has a trigger. And the medication is to reduce symptoms severity. Now, if we don't address the trigger, what is it? What is the cause? Let's just use the cause so that it's easier for people to understand. If we don't address the cause, then the symptoms will flare up at another time. So they will come back to me, and therapy is to identify the triggers and deal with the triggers and resolve the triggers. Therapy will also do skills training and education. Because one of the things that will happen, if I don't educate our client, even why they need to continue to take medication, then they will stop. So I'll also do part of the drug adherence education, why it's important for you to do that. And me and Daktari, we keep in touch throughout. Because then when the patient goes back to Daktari after a month, I need to inform Daktari what we have been doing and the progress. And whatever she picks up, she will send it back to me and tell me this is what is going on. So we complement.
Yeah,
We
see
don't
that.
compete,
Yeah,
we complement. Yes.
Yeah, I can see that. And I'll come to Daktari a little later.
Before we talk about before you come back to me,
Yes.
let me bring myself.
Please do.
Yeah. So the thing is, management of depression has two components. Has that part for drugs and has part for psychotherapy.
Yes.
So if we understand it that way, then it is not asking whether I should be treated by the psychiatrist or do I still have a need to see a psychologist. Because treatment of depression requires
Those two
that you do
aspects.
psychopharmacology and psychotherapy.
Right.
Where these two difficult words are very simple.
They
One
sound
is
very
medicine,
difficult.
medicine, tablets or injection or liquid medicine. And the other one is therapy,
And
which you call a talk therapy.
no,
but
you
has
just said
other
it.
things.
So that
Or
one,
counseling.
that's
Or
For
counseling.
those who like the
Actually,
term
it's easier.
counseling.
Counseling. Let's say
counseling, yeah.
counseling.
Because people are familiar with the word counseling.
Yes, let's use
But when
counseling.
they hear pharmacology, that's a frightful word for the common person like me, who does not have any knowledge of medicine. But when you say drugs, medicines, I understand that easily. People, we understand that. I think we understand that easily. And when you say counseling, we understand that easily.
Not psychotherapy.
Yeah. No, when you say psychotherapy, that's how psycho, Yeah. But that's very helpful to know that the two actually go together. The medical part, the drugs. I need to take the drugs if I am the patient, and I also need to be counseled, need to be talked. The talking therapy. I think I like what you said. The talking therapy, so that I can get the education, and I can get the instruction, and then the information, isn't it? Yeah. But this one comes to Daktari.
Yes.
We talk about side effects of medicines. What are the most common side effects of the mental health drugs or medicines that our young emerging adults need to be aware of, and the parents as well?
The Side effects of the medicine.
Of the medicine, of the
Margaret?
drugs, yeah, the medicines we give or you prescribe.
That is not like, it's not like there's one answer to that. Yeah, what we normally do, and actually what the pharmacists or the chemists should do when they are giving you a medicine, is to be able to tell you that these are things that may happen. If you see them, come back or do 1, 2, 3.
Or stop
if
that
you see
drug.
something unusual, you alert. Yeah.
Yes.
Yeah, so there are several drugs, several medicines that we use that if we start giving just a few, then you see the young adult will be imagining that for every medicine that I take, this happens. Again, what happens about side effects? A small percentage of people, some are even like 0 point something % of the people who use the drug get the side effects. Some will be 1%, some will be 3%. Yeah. The unfortunate thing about the side effects is we really can't tell until you get it. Yeah, sometimes people are saying, no, if you know it's that, doctor, why do you want to give me this? Am I going to get the side effects? We can't tell.
So wait and see.
We can't tell. But you see, we leverage on this bit, that 1%. There are actually some conditions I've not seen at all. And I've been in practice in psychiatry since 2006. 2004, not even 6, 2004. So there are some things that are read. And actually that is also important for the young people. And even you, Reverend Maggie. I know sometimes when you are given the drugs, you pull that slip.
Yes, there's some literature there.
Yes.
And I read all of it.
That thing, if you read it, you can't take any medicine.
If I read all of it, I fear all the side effects. There are so many, and I realize I can get all of them. So it's true, you're right. You get afraid.
That's what I'm saying, that if you go to that list of side effects, you cannot take any medicine. Yeah, the thing is that all medicines have some side effect, but the people who develop the side effects are few. Yes, sometimes patients actually are always waiting. They are in anticipation, waiting for this side effect year after year, because some of them are on medication for a long time, and they don't see it, and they're just wondering, but I was told that I would get this. Yeah, so this is just what I'm trying to say. That's a small percentage.
We'll get the side effects.
Anytime you are given medication, you'll always be alerted that if you experience 1, 2, or 3, please alert us. Those are now the side effects, because those are not expected. I mean, they're not to make you better, but you can get them because of the drug that you are taking.
Wow, thank you so much. Let's dwell on drugs a little bit so that I can ask you this question. How long should a patient continue using the same drug before review?
Hey, Reverend Margaret, your questions are very difficult today. I call them difficult because, which is also good, because it makes me also understand the mind of my patients. Because they're like, oh, should I be going for review every day? So maybe I want to put a few things about depression. The problem with depression, and the reason why sometimes patients go on medication for a long time, is that an episode of a major depression can last 6 months. So then that means that the minimum that we should actually put you on medication is for 6 months, unless there were some triggers that we can deal with and you are not severe. This one I'm talking about the severe depression. Because every time, after about 3 months, then everybody is asking, the family, the patient, oh, do we need to continue taking this again? Do we need to come? Oh, okay, the visits are too frequent. Why do you need to come monthly? But these are things because of the nature of depression, the illness itself. We understand that. And if people are not treated well, then they are likely to relapse. So a lot of patients, I mean, they're likely to get the symptoms again. A lot of patients actually don't finish medication, and they imagine that it's a relapse. But we tell them, we actually didn't finish treatment because you only took your medication for 3 months.
Wow.
And I told you to maybe rest a week, we see, and you thought you were well, and you never came back. Or even the whole family actually confesses that, so-and-so was so well, was now able to, we were seeing the person we knew. We were seeing the person we knew, so we didn't see the reason to continue with medication. So reviews will depend on the clinician who has seen you. And there's no standard review, because remember, there are many triggers. So individuals are unique. Individuals are very unique, and I think I keep on saying every other time even when you compare yourself with somebody your age, or even in the same class, or even if you are two reverends here, started working together, there are those things that define you that don't define the other person. There's a way that you react to different situations. So that uniqueness is also there when it comes to how people respond to their medications.
Thank you so
So
much,
one
Dr.
should just be able to follow the program that they agree with the clinician, because they have there's a basis for you to come after 1 month, or even after 2 months, or even after 2 weeks, or even after a week. Sometimes even the doctor may want to see you after 3 days. Yeah. Okay. And it's very specific, and it's because of the situation. So there's really no common time, but it depends on each individual's need. Yeah.
Thank you so much, Dr. I think I've heard you say this, that it's so important to follow your routine for medication. It's also very important to go for reviews. And it's also very important not to determine that you are well. Let the doctor do that for you. I caught that very well. And then, Doctor, you said we are unique. Every individual is unique. And the Bible says we are fearfully and wonderfully made. So that's what makes us unique individuals. So we're going to take a break right now. And when we come back, we're going to look at more management options. So thank you guys for watching. Stay tuned. We will come back in a bit.
Safari iliyo na machungu, tulizo langu ni wewe tu. Rafiki wa dhati asiyebadilika, mwaminifu kuliko ndugu. Katika safari iliyo na machungu, tulizo langu ni wewe tu. Rafiki wa dhati asiyebadilika, mwaminifu kuliko ndugu. Milele nitakufuata, sitahofu kwa maana unami. Gongo lako na fimbo yako zanituliza, nitakaa nawe milele. Macho yangu yanapojawa na machozi, amani yangu ni wewe tu. Aliye na penzi lililo kamilifu, naloweza kutumaini. Macho yangu yanapojawa na machozi, amani yangu ni wewe tu. Aliye na penzi lililo kamilifu, naloweza kutumaini. Milele nitakufuata, sitahofu kwa maana unami. Gongo lako na fimbo yako zanituliza, nitakaa nawe milele. Natamani mbinguni pasipo machozi, furaha yako ikiniliwaza, kifuani pako nijilaze, unitulize. Natamani mbinguni pasipo machozi, furaha yako ikiniliwaza, kifuani pako nijilaze, unitulize. pasipo machozi, furaha yako ikiniliwaza, kifuani pako nijilaze, unitulize. Milele nitakufuata Bwana, sitahofu kwa maana una.
Welcome, guys. It's nice that we are back, and thank you so much for staying tuned. I want to read a few comments and a few shout-outs to our viewers this afternoon. Grace Caveso, I see you, and you said it's sad to know that so many people suffer from depression, and to imagine that some people imagine that it's not a disease. Thank you so much for that comment. Nyabula Nyaga Kariuki, you are tuned in, and you are saying, I think the reason we have so many cases of depression is because people fear. I added that word fear, looking for help. We may need to examine why people fear looking for help. It's a sign of weakness. That's Nyabura's comment. So thank you guys for staying tuned. And we want to start with that comment. Why is there fear for seeking help? Why are people not quick to go to look for help? When you have a cold, we dash. When we have any fear of like malaria, we dash for help. Why do people fear going for mental health help? Margaret.
Thank you very much for that comment, and just for bringing it out. One of the reasons is, like we said last week, if I remember, issues around mental health, people approach them from a stigma point. And a bit of discrimination. And I think it's from a point of also you don't have the knowledge and, of understanding what are the different mental disorders. And we also come from the place where we don't know of any other mental disorder other than the extreme one that we know, schizophrenia. So anyone who out there with the common person who, if you're talking about mental, anything mental, the first thing that comes to mind is you're mad, for lack of another word.
Yeah.
That's where we all come from. But there are so many of them. There are so many of them. So the fact that we don't first and foremost understand what is it about this person, what are the causes, what are the triggers, and we don't understand the science, then we all stick with that one person who is now, manifesting the negative symptoms that are a bit extreme. That's where we come from. So that's why people fear, even, coming out and saying, I think I am struggling. Because then the perception of the general person out there is from a very an understanding point and from a point of discriminating this individual. But what we are saying, there are so many of them. What you see, the one individual you see in the marketplace are not as many. And that's just one of the many among the mental health disorders that we are talking about. Yeah.
All right, thank you so much for saying that, Daktari.
Reverend, let me just start from where she has left. That one person that they see in the marketplace, they've seen the person for several years. And I just want to re-emphasize that point. Actually, 80% of mental disorders are what we call common mental disorders. Yes, they are not the chronic one that will be there forever, that you will be not able to function, yeah? Because the challenge with society is they have seen this person, even my village, it's like the last, when you were growing up, then you see this person 20, 30 years, they're still the same person. So I think that also has a big issue to the young person. That if I'm going to say that I have a mental, then that is one. But the other bit is like, I don't think I'm that sick. Because the people
like
who
that
are, yes,
person.
I'm not like that person. I'm able to go to work, I'm able to do my schoolwork, I still perform. 80% are those common mental disorders, anxiety, depression, where you are still able to do your things.
Yes.
But you are not fully active. Because for us, mental health means that you should be able to cope with daily stresses of life, be able to perform fully
Optimally,
your full potential, reach your full potential in anything that you are doing. And thirdly, should be able to contribute
Wow.
productively to your society. So this is where we are saying there's a problem. The moment you realize that you are not able to make all these,
Yes.
we are actually in mental health issues. Yeah. Not necessarily the very severe mental illness.
Right.
Because mental health demands that you should be able to deal with daily stresses of life.
In the usual manner.
Those traffic jams.
Yeah.
Oh, this thing of now we are locked in, you know?
Yeah.
Yeah. And it's the reason why we are still saying that there's a lot of mental health issues with the lockdown.
in the society, at this time.
So that bit is where we seem to disconnect. That we think mental illness is that very severe person you see is not able to know whether they are dressed, whether whatever they are eating, where they're staying, and how they are staying. That is not the one that we're talking about. 80% are you and me here.
Yes.
Yes.
With our normal.
You are able to,
we look
able
normal.
to come for this show here. Yes.
And then you said a little earlier, Daktari, that mental illness, we know it because of behavior, not because of the pain. Could the absence of pain be a reason why we don't hasten to find help?
We were basically brought up and inducted that if you are sick, there must be a problem, there must be pain. How many times do you go to hospital and the first thing unauliza shida iko wapi? Unasikia uchungu wapi? You know, where is the problem? So when it becomes difficult that you can't point my leg, my hand, my chest, my head, where the head should be paining. So here a lot of times you don't have the headache. So how do you say that there's a problem?
Yes.
And you can't point it. So this is one of the challenges that I can't say where this pain is. And when I'm going to be asked, uko na uchungu wapi, where is that pain from?
Yeah.
Where are you feeling bad? And they can't
They
pick
can't
it.
pinpoint.
Yeah, they can't pinpoint it because it's supposed to be like physical. Yeah? And remember my language, I told you we say that physical illnesses and ours is mental illness, where we refer to any other medical condition as physical, because it's very easy. Somebody say, my thyroid, I went to the hospital, they found I have a problem with my thyroid, I had a problem with my ear, but now this one is difficult. Where? Yes.
Well, thank you so much for bringing that one out. So we want to now look at the management options, and we want to see how those ones are done and how they affect affect the family. So, Margaret, if you could start us off and tell us, what are the management options from a psychological or psychosocial point of view?
Like we said, the management of depression and other mental illnesses is two-pronged. The big word, pharmacology, and the other big word, psychotherapy or counseling. And they go hand in hand. Now, let me talk from a psychotherapy or from a counseling point of view. So you first want to establish what is the trigger. What is it that pushed this individual to the state or to the point where they are at? And when you're looking at the trigger, you also want to pay attention to who else is associated with whatever the problem of whatever the cause is. Is it work related? Because what does counseling do in general? Counseling responds to, is the problem or the trigger work related? Or is it relationship related? Or is it about the normal day-to-day functioning?
Right.
So if it is, when you identify what the trigger is, then as a psychologist, I have my toolbox, which is the skills that I use to help the individual. And I have another bigger toolbox. You know, the mechanic have a toolbox. that has spanner number 10, 14, and I don't know what.
Yeah.
Now, for a psychologist, my toolbox has skills. The listening, the observation is very important, the questioning,
Right.
and all that. And then in my toolbox, I have what we call the treatment modalities or the theories. Because the theories will help me understand this individual from their childhood, their development, the age at which they are at, and the issues that they are dealing with. So I'll go back to my toolbox once I know, and I'll know what to use. But it goes a step further from bringing in on board who is going to be this individual's support system. Because we have the risk factors, that those things that make you vulnerable and prone. And we have the protective factors. So we work towards reducing the risk factors and increasing the protective factors. And the protective factors here we are talking about, like the support system. Like resolving the relationships. So if the trigger was a relationship, you want to resolve the relationship challenges so that now the relationships do not become a risk factor, but it becomes a protective, factor. Yes.
Oh, I love that. I love that one. Now, we want to continue, Daktari, and see at what point will you involve the family in the management of your patient?
I'll get back to issues of what were the causes or the triggers. And when we see our clients, what is most important is this person is living in a community, and there are people who were living with the person, and they've seen the change. Because the symptoms of depression, there are those that are behavioral. People will see that you are withdrawn, you like isolating yourself. When they are looking at you, they really don't know whether they should talk, or you've now become so quiet. The vibrant you is no longer there. When again they look at you, motivation, you've lost interest in the things that you are doing. Maybe you've even stopped going to work, you don't want to go to work. And you can imagine the way getting jobs right now is very difficult. Or even if it's your business that had peaked and then you suddenly don't go, how it affects the bigger family. Then there's also issues of the symptoms that you have, what we call the pains or lack of sleep, you're not eating, those kind of symptoms. Weight, you have lost weight. When people look at you, they're just wondering, who is this? Cognition, you're just a negative thinker. There's nothing that is going to happen. You are feeling worthless. Yet people can see you are doing so much. But to you're feeling so worthless, so pessimistic that the world will really not be any better. So from this, the moment we are dealing with you, these people around you are very much affected from that change.
Right.
Now you can imagine Reverend Maggie, now you say that, but the pulpit, not anymore.
No interest.
To tell you, today, you're the one who's supposed to be giving, and it's a Sunday, I'm not going. No, you're telling your people you are not going.
They're waiting for you.
And your family.
And your family.
You live with everybody on Sunday, this time you're the one who is not living. So that effect, you can see that from day one, actually the family is affected. So for us, what is most important is to be able to explain to the family what is happening. And also, we also actually send them for therapy as well, family therapy. But outside that, the bit of medication. Because this person may not even want to take the medicine. Two, this person may have even lost the job or is not working. You can imagine an adult who has no job, because this is the group we are talking about.
Right.
Then their family members need to be able to support them by buying this medicine. Two, again, they'll need support to take this medicine. Because the diagnosis alone may already be a challenge on this person.
So the family is so needed here.
The family is right in the middle.
Wow.
Because again, that family is very important. Because if they are going to think that this person should not take medicine, and this is very common, you'll get a Dr. Google or a Professor Google who comes in
Yeah.
and says that, my brother, my sister, in fact, don't give her. Oh, Mom, don't give her. Dad, don't buy that medicine. I've just checked, and it is, no.
So
don't
there are
buy
so
that
many
medicine.
doctors
Yeah.
also.
Yes. So that doctor around the patient
Yes.
can interfere
That's a good,
with the
important
real
counsel.
doctor for that patient at that time. Yes. So
Wow.
that bit of the family to us is always actually it's even the bigger challenge than even the patient. The patient is willing to take the medicine, but
the surrounding
this
community?
doctor, Professor Googles, yeah,
The-
are so many,
Wow.
and they will tend to waver. So one time, the compliance is actually one of the things that will not be very okay, because the patient will take when they're with this, when with the other family member,
Don't take.
they're not taking. Yeah. Or even they refuse to buy anymore. Or they say, let's just give only, they say twice a day. Let's give
Once.
only once. Yeah. Twice is so much. So they are actually rewriting a prescription, which
Oh, look
even
at that.
Margaret here, who is a clinical psychologist, cannot write.
Yes.
Yeah.
But the doctors at
Yet
home.
she is trained,
Yeah.
and she knows what
Yes.
should be written. So that is actually the bit of the family. And so for us, we engage the family very early, and it's the reason why in the history we want to know who are these family members. Yes. So that if we are told there is this or
So do you
that
normally have
comes
a
up-
session with them?
When they come, we have the person who accompanies the patient, we talk to them.
Yes,
Yes.
All
Yeah.
right.
Once in a while, we do a family session, but many times I normally want that to go to the psychologist because there are many other areas that they are able to deal with.
Yeah.
Yes.
That's very important. And thank you for highlighting that because this is an information age. And Dr. Google is accessible on our headsets like this. And we want to help. We think we're helping, right? We want to help our sibling, our emerging adult by saying the doctor wasn't right. I'm more informed than the professional. So thank you very much for that highlight. I think it's very well understood. One of the comments I've read here is that one of the reasons why there's a challenge with mental health is of the stigma. And that man or that odd man or woman that we've seen for a long time in the village could be the reason why we don't want to look like that one.
And I think,
Yeah.
Pastor Maggie, it's very important to add what Daktari is saying here about medication, because we see this almost every other day. You will get these home doctors who even will come from a totally different school of thought, and they will be like, no, I also know that someone else is using herbal medication to treat that, the side effects and everything else that they come from. But it's important for the listener to understand, even when you're talking about changing a prescription, it needs to be changed by a clinician. Not any other person.
Not a sibling or
Not
an
any
auntie or an
other
uncle.
person. And because then Daktari has your history, they know what they prescribed the first time, they know the reasons why they changed to the next one, and they know how long you're supposed to. But mental health, mental illness, you just don't stop abruptly. The doctor will walk you through a systematic way of weaning you out of that medication, because then there are also consequences of abruptly stopping the medication. So it's to appeal to them, please, before you think that one of your own needs to stop, can you go back to the clinician? Yes, and let the clinician guide you and walk you through that process, yes.
Thank you so much.
And then we also have the other challenge of hopping from one doctor
To another.
to the other. And then,
Second opinion?
yes, second,
Or that
third,
opinion.
and fourth opinion.
Then
It's
fourth
okay.
opinion.
But then now, what you also don't understand, when you hop from one to the other and to the other, then there's discontinuation of treatment. And
That's
you
a
go
good
and
point.
start with another one from a certain point. And because you've not been referred, then there is no history that is being passed on from this doctor to the other doctor. So when they come to the psychologist and you appear to really be firm with them in the way you're working with them and trying to resolve the issues, and we come from the place of a family shame that binds us together, so we don't want people to know our family too much and to address the real issues. So what do? We won't go back to Margaret and will discredit Margaret as someone who doesn't know what they are doing, and then we want to go to another psychologist
A new
so that we
person.
give them a different version
Ah,
of the story to cover what we want. You must always remember as a family, it is in the best interest of one of your own to get effective help. So that then whatever it is you're dealing with is resolved. Yes. So before you move, it's nice to stop and ask yourself, why are we moving? Yes.
I think the goal of the family or the patient is to get better. So we don't want to be sabotaging that goal of getting better. I think our time is looking like so gone. I'm going to be asking us to give us a final parting shot. But before I do that, I just want to give a few more shout outs and see whether we have more comments. I can see Micah Muhuyi, you're tuned in, and I welcome you, karibu sana. And Jackie Dida Ochuka, you are tuned in, and you're saying, how about also tackling how to avoid getting depressed? What measures to take or practice? I think we can embrace that as we give our final comments. What measures, how can we avoid being depressed? I think that's a basic question. And I remember, Doctor, you talked a little bit about feelings, you know? Feelings are important, and we talk about the good feel. You always talk about a good hormone that helps us cheer up. Talk to us about how to avoid being depressed.
The first thing I'll say is name it to tame it.
Just say that slowly, nice.
Okay.
Name it
Name it
to tame it.
to tame it.
That's a good rhyme. But what
Yes.
does that mean?
That means let's acknowledge what is disturbing us. Because for us to tame it, before we get into a depressive state, we need to name it. And then once you've named it, you can deal with it. And only then can you tame it. So let's stop, let's be the kind of people who acknowledge what we are dealing with and look for help and seek for help at the earliest opportune time. Then you will have tamed it. Yes.
I think I like that one. Good, Dr. Would you like to add something there?
Yes. How to avoid getting depressed? We all have we all have a powerhouse in ourselves that things happen to us and we're able to go over them. Sometimes we don't even realize that it was so difficult. But then again, if we are kind to ourselves, I have to call it kind, you definitely know when you are not working or when things are not working for you. Yeah. Even when I go to the office and I'm not able to, something I'm supposed to do for 2 hours and I'm doing it for 6 hours. Even as much as I'm seated there and I may say that I don't know what's happening, but there's something that is happening at the back of my mind. There's something that keeps me busy, that is preventing me from doing this. So these are just small telltale signs that when you realize that you are not performing, then you need to find out, why am I not performing? There are those things that will be there. Name those things that are making you not perform. Name those things that are making you not sleep. Yeah, because actually when you sit with yourself, you know, when say have a meeting with yourself, you will definitely be able to say, yeah, last night I didn't sleep well. So what is it that was preventing me from sleeping? Yeah, I was waking up and thinking about this.
Yes.
That is what is actually hitting on you, preventing you from that. So try to give yourself time, and anything that doesn't seem to be working, find out what it is. Deal with it. If you can't deal with it, see how to cope with it. Yes. Ask for help. By the way, there's nothing we are inventing. A lot of this 21st century, there's very little innovation. I think I'm seeing a lot only in terms of softwares and wherever. But the things that we are reinventing on how to live a life is really not there. People have lived. Even as we were in the ages of 20s. Yeah, and people will also be in the ages of 20s.
The years to come.
Ask them, how did
they
you go
cope?
about this? Even ask your peers. Yeah, I'm going through that. Even me, that one is supposed to be a problem. So identify it, name it, and then tame it. Yeah, when you can't tame it yourself, come
Find help.
find help. Find help. Yeah, there's a lot of help around.
Thank you so
basically,
much.
that's what I would say, how to identify it.
That is really cool, Esther. I appreciate that very much. I think you have something to the audience. Tell Mamlaka something. Talk to a parent.
To anyone listening to us, and I know you have audience across the world, is that one, the strongest people are the people who first acknowledge what they are going through, and then they go to seek for help. Seeking help is not a show of weakness, but it's a show of strength. And then
Very
number
like
two, the
that.
things that we are dealing with are things that we can resolve. The only thing we need to do is talk it out.
Fantastic. I like that very much. Thank you so much, Margaret.
And thank
Dr.
you.
Give us a parting shot. Talk to a patient or a parent.
For me, what I want to let you know, depression is a disease like any other illness. Any mental health disorder or illness or issues like any other illness. There are medications that are used, and if you take them, if you are compliant and you are consistent and you follow instructions with your doctors, actually you move with them. With your psychiatrist, let me also be even clearer. Yeah, with your psychiatrist or any other clinician who, because we have a lot of people who can be able to actually put you on medication. If you follow that, you will be able to live a normal life. And I think that is what is most important. You'll feel good about yourself. And therefore, we are saying depression is treatable. The pain and the question of asking why I'm taking this medicine and for how long. If we can take our medications for diabetes, if we can take our medication for hypertension, without people even knowing that we are taking, it's the same thing. If you're able to take your medicine, nobody will be able to see that behavior that will make them start thinking you are not well. So we normally say that you may not be able to understand what is happening, but the moment the diagnosis is made, you become your own doctor. Actually, you don't even rely to Dr. Google. You yourself will know that I don't seem to be doing well. I need to slow down. I need to exercise. I need to see my doctor. I need to stop thinking about this that I'm not doing anything about. Yeah, so you can be your own doctor, and you will live an ordinary life, and depression is treatable. And again, medications have side effects. If there are any issues, let your doctor know. We don't have a shortage of medicine to give you. There's no shortage, by the way. We use very little, less than 10% of all the medicines that we know. Yeah, so don't be worried that now this one costs this, therefore I can't take any other. And I've told you that we don't have a litmus test. If you take it, is when we can know there's a side effect. Yeah, but majority don't have side effects. So that would be my parting shot.
That's a good encouragement to our congregation. So if you know somebody who is on medication, encourage them to take the medication. If you have a patient, let the doctor guide. Let us not help with the medication and prescriptions so that we can experience a better mental health. So thank you so much. I appreciate you guys for coming. Margaret, thank you so much for your time
It's always
and
a
your
pleasure.
insightfulness. What a joy. We thank you
It's
so
a pleasure.
much.
It's a pleasure.
Thank you. Daktari, how can we thank you enough? Thank you so much for your time, for sharing those nuggets of wisdom with us today. Karibu sana.
Thank you so much, Reverend Maggie. I'm so happy that today I'm not treating the one person in my office, but I'm talking to many.
Yes.
Yeah.
What an
So,
opportunity.
thank you.
Yeah. And thank you so much. So we appreciate you guys. Thank you so much. And thank you, our audience. Mamlaka Hill Chapel, thank you so much for listening. We are so delighted to have spent this 1 hour with you. And for our visitors watching us from your homes, from your offices, from wherever, I am your host, Margaret Mohia. I'm a Reverend here at Mamlaka Hill Chapel. And it was such a joy to welcome you to our program today. See you next time.